Today I'll be discussing about diuretics. First you should know what is a diuretic. These are the agents, they increase urine outflow. The urine volume they are going to increase, and its pH also, as well as the ionic composition of the urine and blood. You all know nephron is the most important part of the kidney that regulates fluid and electrolyte. Urine formation, it occurs in 3 steps. One is glomerular filtration rate, that is usually 180 liter per day. Tubular reabsorption, around 98% whatever filtered through the glomerulus all will get reabsorbed, and whichever remaining 2% that will start excreted to the urine through the tubular secretion process. Okay, how will increase urine output means either by increasing glomerular filtration rate or decreasing tubular reabsorption. Why we need these diuretics means to maintain urine volume in case of renal failure, to mobilize edema fluid, like if there is an edema, to leave the whatever fluid content in the relieve that whatever fluid content in the edema, in case of heart failure, liver failure, nephrotic syndrome and also to control high BP also we are using these diuretics. Coming to the classification, we have efficacy diuretics. These are also called loop diuretics. Sodium, potassium, 2-chloride co-transport. Their mechanism is this, and in that we have sulfonyl derivative, furosemide, bumetanide, and taurusinide. And next we have medium efficacy diuretics. We have high efficacy diuretics, medium efficacy diuretics. We have their mechanism is sodium chloride symport. They will do means they will inhibit these two ions. High efficacy and high ceiling diuretics, they will inhibit the absorption of these 3 ions. Benzodiazines, thiazides, hydrochlorothiazide, benzthiazide, hydroflumethiazide, benzoflumethiazide. Thiazide like we have chlorthalidone, metolazone, xipamide, indapamide, clopamide. Weaker adjunctive diuretics we have carbonic anhydrase inhibitors, acetozolamide. Potassium sparing diuretics we have aldosterone antagonist, spironolactone, eplerenone. Inhibition of renal epithelial sodium channel we have triamterene, amiloride. Osmotic diuretics, this is the last class, we have mannitol, isosorbate and glycerol. So this classification is important for anesthesia, nursing, BPT, all the students. You may expect 10-mark question also, because along with the hypertension questions, like these thiazides, any diuretics, they may ask for 10-mark questions sometime. So classification is a little bit important, and usually hypertension, these diuretics are one of the, mainly thiazide diuretics are the first choice drug. So there you can get 10-mark question. You should know the classification of hypertension. And here, like usually you'll expect a 5-mark question. High ceiling diuretic, high efficacy and high ceiling diuretic, these are also called loop diuretics, and like this they may get question. And thiazides you may get 5-mark question, and osmotic diuretics you may get 5-mark question. Even carbonic anhydrase inhibitor, potassium sparing diuretics also you may get a 5-mark question. Classification is not that important, but sometimes they may ask. But in hypertension, these diuretics are the first choice drugs, so you should know in detail these diuretics. First you should know how the urine formation occurs. Then we will go for different drugs. If you know this diagram well, you can able to write all the drugs mechanism is given here. Try to understand. See, you know this is a Bowman's capsule. So when any fluid enter into the glomerulus, it will get filtered. You all know. First it enters the proximal convoluted tubule. Here I'm just telling which is important for your exam point of view. Like I'm not going detail about the physiology of urine formation, only to write answer to the questions whatever is required, that much I'll tell. See here, what are the ions will get reabsorbed means one is bicarbonate. Here they have not shown. Two more ions, one is sodium. Next diagram I will show you that. And potassium will also get absorbed. How it will get absorbed, I'll tell you the next diagram. Next part of the this nephron is the descending loop of Henle. Here there is no drugs to add. The next part is the ascending loop of Henle. Here three ions will get reabsorbed. There is a co-transport. One sodium potassium, two chloride co-transport. With this sodium, potassium and two chloride ions will get reabsorbed. The next part we have is the distal convoluted tubule. Here also there is one symport mechanism, that is sodium chloride symport. Here only sodium and chloride will get absorbed, but in ascending loop of Henle, sodium, potassium and chloride will get absorbed. And like if here calcium absorption will also takes place in this distal convoluted tubule in presence of parathyroid hormone. Okay, PTH hormone, calcium absorption will also takes place. And next part we have is the last part, that is collecting dirt. Here there is a reabsorption of, so I'll show you here, sodium, and to compensate that hydrogen or potassium will excrete usually. Okay. Here there are two hormones we have. One is aldosterone that increase the reabsorption of sodium and excretion of potassium. It's already given here. And we have one more hormone effect is there here, that is antidiuretic hormone. If antidiuretic hormone level is more, means here water will get reabsorbed more and urine will be very concentrated. If there is a deficiency of antidiuretic hormone or ADH, then you will get a more dilute urine. Okay, so next diagram I'll show you with in simple way. This blue line indicates reabsorption and the red line is for the secretion. Coming to the proximal convoluted tubule, here they are not shown bicarbonate. Bicarbonate will also get reabsorbed. Sodium, potassium and bicarbonate. These are three ions will get reabsorbed. Coming to the ascending loop of Henle, we have a reabsorption of sodium, potassium and chloride. And in distal convoluted tubule, we have reabsorption of chloride and sodium. And in collecting that, we have reabsorption of sodium. To compensate that, hydrogen or potassium will get excreted. And if that will occur in presence of aldosterone hormone, sodium reabsorption will occur. Antidiuretic hormone is more, water will get reabsorbed, more concentrated urine will be excreted. If antidiuretic hormone is less, you will get very dilute urine. Okay, next we have, see that I told about the how urine formation occurs. We have drugs which acts on the proximal convoluted tubule. We have a carbonic anhydrase inhibitor, like they will inhibit the enzyme carbonic anhydrase. And next, the drug which act on ascending loop of Henle, we have loop diuretics. These are also called high efficacy diuretics. They inhibit this sodium potassium 2 chloride co-transport. The sodium, potassium and chloride will not get reabsorbed. Here in proximal convoluted tubule, they inhibit the carbonic anhydrase enzyme. So bicarbonate sodium and potassium will not get reabsorbed. And distal convoluted tubule, we have drugs thiazides. They inhibit sodium chloride cotransport. So sodium and chloride will not get reabsorbed. And here we have a aldosterone antagonist, that is spironolactone, amyloride, all they will do that work. So they inhibit the reabsorption of sodium and they increase the reabsorption of potassium. And we have a potassium, these are also called potassium sparing diuretics. Like in other cases, there is a inhibition, hypokalemia, the chance of hypokalemia will be more. So they will give a combination of these potassium sparing diuretic. They increase the reabsorption of potassium, that can be compensated. Okay. We'll go each class. High ceiling diuretics, loop diuretics. Main drug in this is the furosemide or furosemide, both are same. Most efficacious diuretic, they act promptly even among patients with poor renal function or not responding to other drug. They inhibit sodium potassium 2 chloride cotransport in the ascending loop of Henle. I think it's not complicated now. In ascending loop of Henle, which cotransport is present? Sodium potassium 2 chloride cotransport. These loop diuretics, they are going to inhibit. So they inhibit the reabsorption of sodium, potassium and chloride ions. Okay. Reabsorption of sodium, potassium, chloride is decreased because this pump is inhibited. Co-transport is inhibited. Also helps in excretion of magnesium, calcium, bicarbonate, all those ions. Side effects: ototoxicity, ear infection, it causes hypokalemia, hypocalcemia, calcium reabsorption also. They inhibit magnesemia, magnesium, chloride, hypovolemia, blood volume is also less. Hyperuricemia. See, these drugs are secreted in proximal conduct, so they compete with uric acid secretion. Hypersensitive reaction contains sulfur. This series have hyperuricemia will occur. I will show you this. So, in proximal convoluted tubule, secrete a variety of organic acids from the bloodstream into the lumen. See, whatever we have loop diuretics, they compete with the uric acid to secrete into a proximal convoluted tubule. So that will increase the uric acid level. The uric acid, it will get absorbed more, and that will increase the hyperuricemia. Okay. Uses: edema, heart failure, liver cirrhosis, increased portal blood pressure, nephrotic syndrome, premenstrual edema also occur, renal failure. So these causes they decrease the potassium level. So in case of hyperkalemia, you can use same. Hypocalcemia, they causes hypercalcemia, you can use. Okay, this is just information. Next class of drugs we have is the thiazide diuretics. This side of action is distal convoluted tubule. They inhibit sodium chloride cotransport. So inhibition of sodium and chloride will be inhibited. Okay, I'll show you once again. See, this is the site of thiazides will act on this site, distal convoluted tubule. Here sodium and chloride cotransport is present, they will inhibit that. So there is a inhibit the absorption of sodium and chloride ions. Okay. Inhibit the reabsorption of sodium and chloride, causes loss of potassium also. Is like when sodium will not get reabsorbed, potassium will also not get absorbed. Decrease urinary calcium excretion. So they'll do this work like by increasing parathyroid hormone. Calcium will not get excreted through the urine by increasing the calcium reabsorption. So here there is no hypocalcemia. Instead we have hypercalcemia due to increased parathyroid hormone. No ototoxicity when compared to diuretics. Hyperglycemia will be there. hyperlipidemia, hyperuricemia will be there. Again here also uric acid level will be high, and hypokalemia, potassium level will be low. Uses: hypertension, refractory edema, does not respond to other treatment, then you can go for these drugs along with the loop diuretics. Nephrolithiasis, renal stones in that case due to idiopathic hypercalciuria, calcium will start get excreted through urine. Because these drugs, they inhibit the urinary excretion of calcium, they increase reabsorption of calcium, so that's why they are using. Hypocalcemia, why? Because they increase calcium reabsorption, so like they can able to increase the calcium level. Nephrogenic diabetes insipidus, it decrease flow of urine. See, there are two types of diabetes insipidus. Diabetes insipidus means urine volume will be high urine output will be high in this case. The one is the neurogenic and nephrogenic. You don't need to go in detail. Diabetes insipidus means you can use this. I'll continue with the next PPT. Thank you.